The third speaker is Roland Gitter. He is the head of investigative cardiology and CathLab in University of Linz. And he will talk us in a very good lecture, which we'll do now. Dr. Gitt?
Yeah, dear
it will be Fetal and Gitter.
Can you hear me?
Yes, go ahead.
Okay, thank you very much to the chairman and dear colleagues, and my thanks to Aphrodite Sifa, the director of the hospital, who invited me. And now it's a change from the main topic of imaging to some practical, and I'm happy to share our experiences, which have become a passion for the last 20 years. Unfortunately, we are not able to put the equipment and the people into the MRI, so we have to stick on plain ultrasound so far. So why do fetal cardiac interventions at all? We have learned that the cardiac valvular disease can progress during pregnancy, and you have a simple cardiac problem in the early pregnancy, it may become a severe one. As you may see here on the screen, that on the 23rd week of gestation, you have an already evolving hypoplastic left heart syndrome, which became more severe only 6 weeks later. So this is the rationale one of the rationales to do interventions on the fetus. So what is the goal? It could either ensure or improve the survival of the fetus. It should improve the intrauterine hemodynamics. And one of the main issues is to avoid univentricular pathway, to save and biventricular circulation after birth, and to improve the long-term outcome of this fetus. Just some practical aspects. In our institution, it's done by the mothers in general anesthesia, and so the fetus as well. We use just simple G1 needles in the size of 19 to 17 gauge. We use small wires and balloon catheters. So the coronary balloons, as they are available, the size is usually 3.5 to 4.5 millimeters. And against the experience from postnatal, the ratio of the balloon often exceeds the valve diameter to 1 to 1.5. One more detail of the technique. So you get with a needle through the abdomen of the pregnant woman, through the uterus, through the thorax of the child, the ventricular wall, and headed to the valve. In terms of time, I will focus on the aortic valvuloplasty. So this is the overall experience. We started in the year 2000. That was somewhat, let's say, experimental then. But over the years, it became an established method, an established program. We got more and more experience and more referrals from other centers and other countries. So it's around 20 of these procedures per year. It's not very much often. It's not an everyday one, but it's rather frequent. So the vast majority is aortic valves, 130, and the rest is pulmonary valves, which are technically more difficult. And in 9 cases, we did balloon atrial septostomy or atrial septal stenting. One of the most important things if you start this program is the patient selection. So we deal with fetuses from the 22nd to the 32nd week of gestation. Before this age, they are simply too small. And after the 32nd week, you have to think about if it's not better to treat the fetus postnatally. So it should have the signs of an evolving single ventricle, either a left one or a right one, which should have the chance of recovery. And another group, it's a different group, are these ill fetuses, which show the signs of a congestive heart failure already and hydrops. So the aim in this case is not basically biventricular circulation, but just to save the survival of the fetus. And there may be associated lesions like a restrictive or a closed foramen ovale with a pulmonary congestion, which you pretty much see them in the MRI, for example. So what means an evolving hypoplastic left heart syndrome? If you look at this picture, this is, let's say, the ideal candidate for treatment. You have a still big left ventricle showing bad contraction because it's not a weak myocardium, but it is the high afterload. You see the signs of the endocardial fibroelastosis. And if you go further, you will see reverse flow in the aortic arch and left to right shunting about the foramen ovale. So the question is this left ventricle salvable? And just to keep it simple, it's a matter of the LV length, and it's a matter of the LV pressure. So in this case, this is obtained about over the aortic valve, and you have a gradient of 3 meters per second. So this is a still good pumping ventricle, which is feasible for treatment. So if you see that fetus, it's a 24th week with critical aortic stenosis. You can see there's relevant mitral regurgitation with a big left atrium. You have the retrograde flow in the aorta, and clearly you see hydrops. So the prognosis of this particular patient is not that good, neither for right ventricular circulation nor for survival. So, sorry, this is just briefly to show how the work is done. The needle is approaching the fetus through the ribs and directly into the left ventricle. Most of the cases, the heart does not stop moving or get arrhythmias or other complications. Here, the wire is advanced through the valve, small wire, followed by a balloon. And here you have the dilatation of this balloon, and afterwards, in the color Doppler, you see nice antegrade and also retrograde flow. This is an example for a typical intervention. So if you follow this case, in the first row was visible the situation before the intervention. In the 30th week of gestation, you see the right ventricle is already unfolded of better size. The left ventricle is still big. The function is not ideal, but better. And the last row, this was the situation after birth. So clearly not a normal ventricle, not a normal aortic valve, but a left ventricle which is capable to serve the systemic circulation. And this is one of the patients who has never an intervention or operation since birth up to the time of 3 years. So this is clearly one of the best of this whole procedures. but you just want to show that it is possible to do this intervention. So what are results over the last 20 years? So in 100 of the 125, it's just aortic valvuloplasty were successful. You see that in some fetuses we did this intervention 2 times or even 3 times. And as there is a learning curve in every technique, the success rate rose in the last years. And fetal demise is relevant, but it's not that often. And in the last 7 years, we fortunately only lost 3 fetuses out of a bit more than 50. So, but what happens with these fetuses after valvuloplasty? Because this is the most important issue. So we analyzed these fetuses after successful prenatal valvuloplasty. So 78 were live-born, and 95, so that 75% had a biventricular management. I have to say that it's not all newborns that were treated in our institution, as the referrals came from different countries. The postnatal treatment was not only in our institution, but other centers as well. What happened after the neonatal period? There were still 57 on a biventricular course. One died, one was converted to Norwood. And after 1 year, there are still 52 biventricular, which means about 60%. And the period after 1 year, as we could follow them so far, they are still a bit more than the half of these intrauterine dilated fetuses are on a biventricular course. So this is pretty much the same information. What is important to mention, these are not only biventricular, they also don't have any signs of pulmonary hypertension. There was an investigation from Helena Gardiner from 2016. She followed the natural course of fetuses with evolving hypoplastic left heart. And you see that in the right column that despite they did not have any treatment, nearly 1/3 of the fetuses had a biventricular outcome without any intervention. And if we compare this group to our group, then I think there is a significant difference. So that 2/3 can achieve a biventricular circulation, only 1/3 is univentricular. We're working on new predictors of biventricular outcome. Our colleague Andy Tulza is working on that, and to keep it a bit more simpler, the picture is complicated, but the result is should be rather simple. So if you have if you measure the ratio between the right and the left ventricle, and the right ventricle is bigger than the left one, the probability of a biventricular circulation is rapidly going down to only 30%, whereas if the left ventricle is big enough, the biventricular outcome is nearly 100%. And this is as well for the fetuses below the 28th week of gestation. One subgroup are the ill fetuses, so aortic stenosis plus hydrops. We had 15 fetuses so far. Subsequently, 3 of these fetuses died, but fortunately this was not related by the procedure. So it was beyond the 48 hours after intervention. And it's always interesting or astonishing to see that the hydrops resolved in most of the cases. And even these very sick fetuses had a good outcome with 50% biventricular after birth. But in the last row, maybe you see that the aortic valvuloplasty in utero is only the beginning of the story. Usually it's not the end, it's the beginning. And the treatment after birth has to continue. So if I may conclude, what we are doing with the valves has the potential to reverse an heart failure in fetuses with hydrops. If you have the experience and do it over a long period, it can be done with a rather good success rate and an acceptable rate of complications. And there is evidence that the outcome is better compared to the natural history. And if the fetus survives, it's a pretty good candidate for biventricular repair. But there are costs. The costs to achieve this biventricular circulation is in almost all cases a postnatal treatment of the valve, which can be either only the valvuloplasty or the aortic valve replacement. And in our cohort, it's up to 2/3 of these patients, which require a neonatal Roscono operation. So the postnatal management has to include also the capability of valvuloplasty or a neonatal Roscono procedure or Novot operation or hybrid procedures, or to distinguish between these two techniques. And then the result of the in utero procedure can be ensured over the long run. So I thank you very much for your attention, and warm regards from cold Austria.
Thank you very much for 3 excellent lectures.